Hello friends, let us come to the next topic, that is the vocal fold palsy. Now the vocal fold palsy, this topic deals with as much physiology as it deals with the pathology. Okay, so if you understand the anatomy and the physiology of the movement of the vocal folds, then you can very well understand this topic. Okay, so quickly we'll have a quick recap of the important points that we have discussed in the anatomy. Okay, so anatomy means two things: muscles. We discussed the topic of muscles of the larynx, the intrinsic muscles, and second was the nerve supply of the muscles. Okay, so we quickly have a recap. We know that the larynx is supplied by the 10th cranial nerve, that is the vagus, and we have the superior laryngeal nerve and the recurrent laryngeal nerve, two branches of the vagus. Now the first thing that you have to remember is that the recurrent laryngeal nerve, it supplies all intrinsic muscles except cricothyroid, which is supplied by the superior laryngeal nerve, right? Okay, so that was the first thing. Now the second thing was that all intrinsic muscles of larynx, what are they? They are all adductors. Okay, so all of them we know they are adductors except one, that is posterior cricoretinoid, PCA. So PCA, posterior cricoretinoid, this is the only abductor of larynx, rest all are adductors, right? Okay, now the third point that you have to remember is that the vocalis muscle, this is the relaxer of vocal fold, and we have the cricothyroid muscle, this is the tensor of vocal fold, right? Okay, now the last point that you have to remember in this whole nerve supply is that the recurrent, especially the left recurrent, it has a longer course in the thorax. Okay, so therefore it is more prone to the injury, right? All right, so we go ahead, we discuss the topic of vocal fold palsy. Now before I start with the topic of vocal fold palsy, let us look at the position of the vocal fold. Okay, so let us know in what all positions the vocal fold can be there. Now the number one is this position. Which is this position? This is the median position. Okay, so the vocal fold is in the center and it will meet the opposite side vocal fold, right? So both the vocal folds, they come in the center, they meet, and this is done when we have to produce voice. So this is full adduction, right? This position is full adduction. Now to have full adduction, it will require the action of all the adductory muscles, right? So just remember that it will require the action of all adductory muscles. Remember phonesthesia. So if some muscle is not working, the vocal fold will not be in full adduction. Now this is the full abduction. Okay, so now full abduction, the adductory muscles have to undergo relaxation, but something else have to act. So which muscle has to act? The posterior cricoretinoid muscle, this muscle has to act. So adductory muscles, they have to undergo relaxation, but the posterior cricoretinoid has to undergo complete contraction. So then we have a full abduction. Okay, now the third position in which we can find the vocal folds, that is the cadaveric or the intermediate or the neutral position. Okay, so you can see this is in the center of adduction and abduction. So this is cadaveric or intermediate or neutral position. So this position of the vocal folds will be there when we don't have any adduction or abduction function. So neither the adductory muscles are acting nor the abductory muscles are acting. All right, so that is a cadaveric position. So that means after death in the cadaver, we'll find this vocal fold in this position. Okay, because there is no muscle action, neither adduction nor abduction. So this is the intermediate or the neutral position. If we cut the 10th nerve for both, the adductory and the abductory muscles, so now the vocal fold will come and lie in the cadaveric position. Now the last position is the paramedian position. So what is paramedian position? So it is not median, it is paramedian. That means only some adductory muscle is working, all adductory muscles are not working. Okay, so the vocal fold will not lie in the median position, the vocal fold lies in the paramedian position. Alright, so it is like 1 to 2 millimeter away from the center, as you can see over here. So this is your paramedian position, right? So just remember these position and then we can discuss the vocal fold palsy, right? Okay, so this question has been asked in the JIPMER May 18 exam. Neutral position of the vocal folds is, so we know neutral is cadaveric or intermediate position. So that is our answer over here. It's a straightforward question. Okay, now let's go to the vocal fold palsy. So in the vocal fold palsy, the first thing that we have to remember is the two principles or laws. The first is the Siemens law. Okay, now what is this Siemens law? Now Siemens law is that in case of a progressive neurological lesion, okay, in case of a progressive neurological lesion, so when I say progressive neurological lesion, you know, I can mean myasthenia gravis. Right, so that's a progressive neurological lesion. So in case of a progressive neurological lesion, the abductory fibers are affected first, as they are phylogenetically new. As they are phylogenetically new. Now, what do we mean by this statement? Okay, so let's first understand the Siemens law, then we'll go to the second principle. Now, this law says in case of progressive neurological lesion like myasthenia gravis, now what happens? It talks about basically a nerve which is our recurrent laryngeal nerve. Now you see, the recurrent laryngeal nerve supplies all intrinsic muscles of larynx except the cricothyroid, which is supplied by the superior laryngeal nerve. Alright, so that means it is supplying all the adductory muscles, okay, except cricothyroid. It is supplying all the adductory muscles, as well as it is supplying the only muscle for abduction. So the only abductory muscle, that is your posterior cricoid. So that means this nerve is causing both the actions, adduction as well as abduction. So Siemens gave this hypothesis that maybe recurrent laryngeal nerve, this nerve has two kind of nerve fibers. One fibers they cause adduction and the other fibers they cause abduction. Right? Okay, so that was the first hypothesis in this law, which we cannot prove, but we cannot even disprove. Right? Okay, so this is the first hypothesis of this law, that it has two kind of fibers. Now, it then means to say that the primary function of the larynx is protection of airway. Right? Primary function of larynx is to protect the airway, and to protect the airway, to prevent any foreign body from entering into the airway, what action do we need? We need the adduction. We need these adductory muscles. So they will contract, they will stop the entry of any foreign body. So the Siemens said that the function of adduction is a old function. This is the primary function. So this is a phylogenetically old function. Okay, so phylogenetically this is a old function. Right? Now, whereas the abduction, the function of abduction, it came late. Right? Okay, so this is a phylogenetically new function. Right? Now it says the next thing, that in the genetics we know that something which has developed new is more sensitive, it is more prone to damage. Something which is old, okay, that is more stronger, it will stay for a longer time. Any function that we have recently gained in the evolution, okay, it will be more sensitive. So this Siemens law says that in case of a progressive neurological lesion, so suppose a patient has a progressive neurological lesion, and let's say this lesion, it affects the recurrent laryngeal nerve. Okay, so this lesion, let's say it affects the recurrent laryngeal nerve. Now what will happen? Now which function of the recurrent will go first? When this is affected first, the first function that will go is abduction. Okay, because this is a phylogenetically new function, so this abduction, it will be lost, and therefore what will happen to the vocal fold? The vocal folds, because the function of abduction is lost, there will be an unopposed adduction, so the vocal fold will go into the median position. Okay, or you can say paramedian position, depending upon how many muscles are acting. Okay, so they will go into the median or the paramedian position if the abduction is lost. Right? Okay, now this was your Siemens law. I know this law is quite complicated. The problem with this law is that we cannot prove or even disprove this law because it is all hypothesis. All right. Now, against this, we have that second law, that was the Wagner and Grossman hypothesis. Okay, so this principle, the Wagner and Grossman hypothesis. Now, what does this law says? This hypothesis says? This says simply one thing, that whether it's a progressive lesion or it's an acute lesion, if the recurrent laryngeal nerve is affected, okay, so that means all the muscles are gone. That means both adduction and abduction, both which are supplied by the recurrent, they are gone. But in this scenario, we still have the superior laryngeal nerve. Okay, and this superior is intact because only the recurrent was affected. So if there is a recurrent laryngeal nerve lesion, the superior laryngeal nerve is still intact, and therefore the cricothyroid muscle is still acting. So remember, cricothyroid is the tensor of vocal fold, and other than tensor, it is also an adductory function. Okay, it causes adduction. So therefore, because of this unopposed adduction, because the abduction is also gone, so only one muscle is there, and that has a adduction action, so it will cause adduction of the vocal folds. So vocal folds, they will come to lie in the median, or we can say paramedian position. Right? So is that law clear to you? So you know, both the laws, they say the same thing. The Wagner law is more logical to me. Personally, I feel that this is more logical because it says that if recurrent is gone, we still have cricothyroid muscle acting, and therefore it will cause adduction and vocal folds will be in the median position. The Siemens law is a little confusing, okay, but it means the same thing. All right, it has a lot of hypotheses in it which we cannot prove or disprove, but ultimately both the laws, they mean the same thing. Right? Okay, now with this information, we come to the vocal fold palsy. So, vocal fold palsy, we first discuss the unilateral vocal fold palsy. Okay, and the first unilateral vocal fold palsy we have to discuss is the external laryngeal nerve palsy. Okay, external laryngeal nerve palsy, unilateral, most common cause is thyroid surgery. Right? Now, these questions are asked, which is the most common nerve injured in thyroid surgery. Okay, remember, thyroid surgery, most common nerve that is injured is external laryngeal nerve. Okay, most common nerve injured is external laryngeal nerve. Out of the recurrent, which is affected first, right or left? Now we know left has a longer course in the thorax. So left is more commonly injured in cardiothoracic surgery. Okay, but right is more commonly injured in neck surgery. Right? So right recurrent laryngeal nerve is more commonly injured in thyroid surgery, and left is less commonly injured. Okay, right is more superficial in the neck. Sometimes right may be non-recurrent laryngeal nerve, as we have discussed earlier. So because of this, right is more commonly injured in thyroid, that is a neck surgery. Okay, if I talk about cardiothoracic surgery, left is more commonly injured. Overall, if we take, again, left is more commonly injured than right. But in neck surgery, right is more commonly injured. Okay, so Most common nerve injured in thyroid surgery is external laryngeal nerve. That's a branch of superior laryngeal nerve, right? Most common cause for external laryngeal nerve palsy is also thyroid surgery. So both the ways it is correct. Okay, now let's go ahead. Okay, now most common cause for external laryngeal nerve palsy is thyroid surgery. All right, now what will happen to patient? External laryngeal nerve gone. External laryngeal nerve supplies cricothyroid muscle. Remember, this is a branch of superior laryngeal nerve. It goes and supplies cricothyroid muscle. Cricothyroid is a tensor of vocal fold. Okay, so now if cricothyroid is gone, the tension is gone. That means the patient cannot increase the tension. If the patient cannot increase the tension, he cannot speak in high pitch. This high pitch voice is gone. Okay, so patient has a low pitch voice, loss of pitch. Patient cannot shout too much. Patient cannot exert that much force because the pitch of the voice is gone, right? Okay, now what do you need to do in these patients? First of all of us, we don't require the pitch. Only a professional singer requires as much pitch. So if it's a case of unilateral external laryngeal nerve palsy, this patient will not even notice this palsy. Okay, if it's a case of unilateral external laryngeal nerve palsy, patient will not even notice. There will be no complaint. You will also not come to know that there is a loss of pitch. So there is nothing to be done. Okay, except in case of a singer. Singer will notice that there is a change in voice. There is a loss of pitch, right? And if there is a bilateral external laryngeal nerve palsy, then yes, the most commonly the patients will notice the loss of pitch, right? But once again, nothing has to be done because the patient is able to speak normally. Only the pitch is lost. All right. So you have to do only conservative treatment. Bilateral external laryngeal nerve palsy, again, that is seen in case of thyroid surgeries. All right. And again, the treatment is conservative treatment. So remember, this loss of pitch is mainly noticed when it's a bilateral external laryngeal nerve palsy. Yes, remember, if there's a bilateral external laryngeal nerve palsy in a singer, now his life is going to be ruined because for a singer, the pitch is very important. But for a normal person, this is not an important thing. Okay, now let's come to the next, unilateral recurrent laryngeal nerve palsy. Now the recurrent laryngeal nerve palsy causes both loss of adduction and abduction, as I told you, right? Okay, so both adduction and abduction function will be gone, but we have cricothyroid muscle, which is supplied by superior laryngeal nerve, external laryngeal nerve branch. Okay, so because cricothyroid is there, that means adduction function is still left. Only abduction is completely gone. So the recurrent laryngeal nerve palsy is also known as abductor palsy. Why we are calling it abductor palsy? Because abductor action is completely gone. The posterior cricoretinoid is not working anymore, so abduction is completely gone. Adduction muscles are gone, but one adduction muscle is still left, right? Okay, so most common we see is the left recurrent laryngeal nerve palsy, right? Overall, left is more common. In cardiothoracic surgery, again, left is more common. But if somebody talks about the neck, like thyroid surgery, then right is more common, right? Okay, next, what do we see? Where be the vocal fold? The vocal fold lies in the paramedian position, right? The vocal fold is in the paramedian position. Why paramedian position? Because of unopposed adduction. Okay, this is because of unopposed adduction. Only one muscle is spared. Which muscle is spared? The cricothyroid muscle is spared. Okay, so this cricothyroid acts and it brings the vocal fold towards midline, but it is not able to bring it to the median position, to this position. Why it is not able to bring into median position? Because to bring into the full adduction, you need the action of other adductory muscles like interretinoid, thyroretinoid, okay, lateral cricoretinoid. So all those are gone. So it is able to bring till paramedian position, right? Now what will happen? Because of this, when the two vocal fold try to meet, there will be a gap. Okay, so as you can see, this vocal fold will come to this position over here, and there will be a small gap. Okay, now because of this gap, we call this gap as a phonatory gap. When the patient try to speak, between the two vocal fold there will be gaps, so that is known as phonatory gap. Now because of this, patient will have what? Hoarseness of voice, right? So patient will have hoarseness of voice, right? Okay, now what will happen because of this? You see, because of this arrangement of the vocal folds, one is moving and coming in the midline, okay, the other is fixed in the paramedian position. Now you see the patient airway is good. Patient airway is good. Patient is able to breathe nicely, right? You can see there is a good airway over here. Patient is able to breathe nicely. All right, there is no problem in the airway, right? Voice is little bad. Now what happens after some time, after a few weeks time, this vocal fold, it will undergo a compensatory hypertrophy. Okay, it will undergo a compensatory hypertrophy, and it will travel this distance, and it will go and meet the other vocal fold across the midline. So this will grow, and it will go and it will meet the other vocal fold across the midline. So that means this phonatory gap, it will disappear after a few weeks time. Okay, and therefore what will happen? The voice will become good, right? So airway was good always, voice became hoarse. Okay, so this is a transient hoarseness. It disappears after some time, right? There's a transient hoarseness, and the treatment that has to be done is conservative treatment. Therefore, nothing has to be done for this. You can understand, patient will improve on its own within a few weeks time. All right, next we come to the condition. Over here you can see that this is a case of unilateral recurrent laryngeal nerve palsy. Okay, and the other vocal fold, it is started to become hypertrophied, and after some time it will go and meet the paralyzed vocal fold across the midline. Okay, you can see that the airway is good and patient is able to breathe nicely, right? Okay, next we come to unilateral 10th nerve palsy. So when I say 10th nerve, it means superior laryngeal nerve as well as recurrent laryngeal nerve. Remember, superior laryngeal nerve means again two nerves, external laryngeal nerve and internal laryngeal nerve. Okay, remember each of these branches, they have separate functions. So all these functions are lost when we have the 10th nerve palsy. Most common cause is surgery. Surgery can be anywhere. It can be the neck, it can be the skull base, right? So most common cause is the surgery. We have other causes like tuberculosis, we have causes like a tumor in the skull base, okay, but still the most common cause is surgery. Now, what happens if there's a 10th nerve palsy? If there's a 10th nerve palsy, that means the adduction as well as the abduction, both are gone. Both the actions on one side are gone, right? So that means the vocal fold will lie in the cadaveric or intermediate or neutral position. Okay, so they are in the cadaveric, intermediate or neutral position. There is no adduction, no abduction, right? Okay, what about the other vocal fold? The other vocal fold is mobile. So other vocal fold we can see is mobile, and therefore airway, you can see patient has a very good airway. Right? Patient has a very good airway. Right? Now what will happen to the voice? The voice is going to be bad. Hoarseness. Why? Because this vocal fold can come and meet over here in the midline. Right? So it can come into the midline. Initially it can reach only midline. Will the voice be good? No. Why? Because the other vocal fold is not able to meet. So there is a gap. At the time of adduction, we can see there is this much of gap. So patient voice is bad. But will this voice, this hoarseness improve with time? No. Why? Because cadaveric position is far away. So this fold is not able to grow this much. Okay, it is not able to grow this much. It is able to reach till the paramedian position, but it cannot go across so much and meet in the cadaveric position. Okay, so this hoarseness is going to be permanent. right? So you have to remember, this is not a transient hoarseness. The hoarseness is going to be permanent. Okay, that means even after a few weeks, after the maximum effort, there will still always be some gap between the two vocal folds. Okay, there will still be, maybe this is the midline. Okay, so let's say this over here is the midline and this vocal fold is able to come till here. Okay, so this much gap will always be there. So one that I am now highlighting, this much gap will always be there even when the foreign body tries to go in. Okay, the two vocal folds cannot close the airway completely. So this much gap will always be there, and therefore patient will have problem of aspiration. Okay, patient has problem of aspiration. Also remember, on this side, on the paralyzed side, even the internal laryngeal nerve is gone. So this internal laryngeal nerve is responsible for causing cough reflex. That means on one side, if the 10th nerve is gone, the cough reflex is gone, so food can easily go into the airway without causing any cough reflex. So therefore aspiration will be a major problem for this patient other than the hoarseness, right? Okay, so presentation is hoarseness and aspiration. Don't forget the aspiration part, very, very important. Primary function is to prevent the entry of foreign body into the airway, to secure the airway. That means to prevent aspiration. Okay, now what will you do for this patient? This patient will not improve on its own. Okay, right? So what you have to do? You have to do some surgery so that you can put the vocal folds and close this airway when required. So we do a type 1 thyroplasty. Okay, so what we do is type 1 thyroplasty. Remember, thyroplasty means surgery on the thyroid cartilage. This is done to improve the voice, right? Okay, so that is your thyroplasty. Okay, these thyroplasties, they were given by Ishiki, and we have 4 types of thyroplasty. Type 1, 2, 3 and 4. We will discuss each of these thyroplasty slowly in this topic, right? Okay, now let's look at this photograph. What do you see? You see a 10th nerve palsy. Both recurrent and superior laryngeal nerve have undergone palsy, and despite the maximum effort, the vocal fold is not able to cross the midline and meet the other vocal fold. Okay, so this much gap remains always in the airway of this patient, right? Okay, now how do we confirm before doing the surgery that we can improve the voice? So there is a test which is known as lateral compression test or a manual compression test. So what we do in this, we take the thumb and the index finger and we press the thyroid cartilage on one side. So you see, as over here, I'm pressing the thyroid cartilage and it moves this paralyzed fold into the midline. So when this is moved to the midline, the other vocal fold comes and meets and the voice improves, the hoarseness disappears. So that shows that we can give an improvement to this patient by doing some kind of surgery. So what surgery do? We put an implant. Okay, this implant can be a titanium implant, it can be a silicone block, and this is a particular shape. Now what is the function of this shape and this implant? It is placed by making a window in the thyroid cartilage. Okay, so as you can see over here, this is the thyroid cartilage, and you make a window in this thyroid cartilage and you put this implant. Now this implant pushes the paralyzed vocal fold towards midline. Okay, so this is brought to midline and the other vocal fold can move freely. So it will move freely, it will meet this paralyzed vocal fold in the midline, so voice improves. Because now the two vocal folds are meeting in the midline, so the aspiration also stops, right? So voice improves, aspiration stops, right? So this is your type 1 thyroplasty, which is also known as needleization thyroplasty or approximation laryngoplasty. Okay, laryngoplasty is again surgery on the larynx to improve the voice. Laryngoplasty can be of different types. Okay, now thyroplasty is a type of laryngoplasty where the surgery is done on the thyroid cartilage to improve the voice. right? So laryngoplasty can even be an injection laryngoplasty, but thyroplasty is surgery on the thyroid cartilage to improve the voice. It is a type of laryngoplasty. So medialization thyroplasty, or you can even say approximation laryngoplasty. So that is a type 1 thyroplasty, right? Two advantages of this type 1 thyroplasty: number one, improvement in voice; number two, stoppage of aspiration. Okay, let's come to this question. What is the symptom of a person with unilateral abductor paralysis? So abductor paralysis, that's a term for recurrent laryngeal nerve palsy. Okay, so abductor paralysis, what will happen to this patient? Now, dyspnea on exertion, no, there is no problem with breathing, the airway is nice. Transient hoarseness, yes, the patient has hoarseness which improves because the other vocal fold undergoes a compensatory hypertrophy, right? Okay, so that is the symptom which is there. There is no stridor. Okay, there is no stridor. The voice is hoarse and not husky. So the answer to this question is transient hoarseness of voice. Okay, let's go to this question. All of the following is seen in superior laryngeal nerve palsy except. So what happens when there is a superior laryngeal nerve palsy? So superior laryngeal nerve means external laryngeal nerve and the internal laryngeal nerve. Okay, so internal is gone, cough reflex is gone, patient will have aspiration, right? That we all know. Now, external is gone, so cricothyroid is gone. So when cricothyroid is gone, that means the tension is gone. So the loss of pitch is there. Yes, so this will also be seen. So because the vocal folds are now relaxed, they are not under tension. So they will be bowed vocal fold. That means relaxed vocal folds. That can also be seen. Stridor is not seen. Okay, so stridor is not seen because of superior laryngeal nerve palsy. It has nothing to do with the airway. Airway is not affected, so stridor is not seen. That is our answer to this question. Okay, let's come to the bilateral palsies now. So we first start with the bilateral recurrent laryngeal nerve palsy. Now, what do we see in bilateral recurrent laryngeal nerve palsy? You see, both the side vocal folds, the abduction function is completely gone. Okay, adduction function is gone, but cricothyroid muscle is spared. So adduction function by cricothyroid is still left. Okay, so this is also known as bilateral abductor palsy. Okay, so this condition is also known as bilateral abductor palsy. Now, most common cause is thyroid surgery, right? Bilateral recurrent is affected, so most commonly it is seen in thyroid surgery. What happens now? Both the vocal folds are in the paramedian position. Because of unopposed adduction of cricothyroid, the abduction is gone. Only one muscle is there, adduction is there, but it cannot bring in the median, it will bring to the paramedian position. So there will be bilateral paramedian position. Okay, the vocal folds are not separating, right? So what happens over here? Only a small airway is left. 1 to 3 millimeter airway is left. These vocal folds will not separate. Okay, so because of this very, very small airway left in the patient will have stridor. What kind of stridor will be there? This obstruction is both during inspiration and expiration. So patient will have biphasic stridor. Right? Patient has biphasic stridor. What about voice? What about voice of this patient? Now you see, these vocal folds, they are in the paramedian position. So there is some gap. But when the patient tries to speak, when the air is passing through this vocal fold, there is a Bernoulli's phenomena. Okay, now Bernoulli's phenomena, the air is passing through a very narrow area fast, a negative pressure is generated. So these vocal folds, when you try to speak, they will come even closer. That's because of the Bernoulli's phenomena. So they come even closer and therefore voice becomes good. So in this case, bilateral recurrent laryngeal nerve palsy, or we can say bilateral abductor cord palsy, patient has stridor. Okay, which kind of stridor? Biphasic, but the voice is good. Okay, remember, this is typical. The voice is good. Why the voice is good? Because number one, the gap is very less. And number two, because of Bernoulli's phenomena, even this gap, the vocal fold can come together during speaking and the voice becomes better. But they are not able to separate. So airway is affected. Okay, these patients, they come in stridor, in respiratory distress. Sometimes you may even have to do tracheostomy to give them a good airway. There is a URI, there is a upper respiratory infection, there is some inflammation, it will go into complete closure. So you may have to do tracheostomy in most of these patients. Okay, now what will you do after this? You'll wait for some time. You can wait after a tracheostomy for the spontaneous recovery of the reclingingal nerve. Okay, that can be done. But if there is no recovery of this reclingingal nerve, then you have to do something. You have to move these vocal folds away to give some airway. So that is known as type 2 thyroplasty. Okay, so as I said, number one thing that you have to do is you have to do tracheostomy. You have to consider tracheostomy. And the number two thing that you have to do is type 2 thyroplasty. Okay, so what is done in type 2 thyroplasty? Type 2 thyroplasty is lateralization thyroplasty. So what you do over here, you give a midline incision in the thyroid cartilage. So you can see over here, this thyroid cartilage is cut in the midline, and then what you do, you place a block over here. You can place a silicone block and separate the two vocal folds. Okay, so that is one way of doing the lateralization or expansion laryngoplasty. Lateralization thyroplasty or expansion laryngoplasty means the same thing. So you cut and you place a block. Okay, so that is known as type 2 thyroplasty. Now over here, let's remember this thing, that there is a surgery which is known as laryngofissure. Okay, so now what is laryngofissure? Laryngofissure also means that you give an incision in the midline of thyroid cartilage. So you give incision in the midline of thyroid cartilage, and then you put retractors and you open the larynx from this midline. This midline does not have nerve supply. There is no blood supply. So this is a avascular, okay, non-neurological plane. You can directly enter into the larynx through this plane. So this is sometimes used for the surgery. Right? So that is known as laryngofissure. So you can open the larynx like this, and if you want to remove a tumor or something, you can just remove it, and then you can close back the larynx, and you can screw this thyroid cartilage with the help of some screws and plate, and then you can close the larynx once again. Right? So this is known as laryngofissure. Laryngofissure means opening the larynx from the front in the midline. Okay? Type 2 thyroplasty over here, however, means that we cut the thyroid cartilage. We don't open it much. We just cut the thyroid cartilage and we put a block over here to lateralize it. Right? Okay. So that is one way of doing the type 2 thyroplasty. Okay. Other people, they also do a suture lateralization. What do? They do suture lateralization. So what they do is they pass sutures from here to the vocal fold, and when they tie the suture, what will happen? It will pull the vocal fold over here like this. Okay, so when you stretch and tie the suture, it will pull the vocal fold and it will create some airway like this. Okay, so some airway is created. Remember, the type 2 thyroplasty or any other lateralization procedure done over here will degrade the voice. Okay, the voice, as the vocal fold go away, the voice will become poor, but the airway will improve. Right now, patient is not able to breathe. The patient may be on tracheostomy, breathing through the tracheostomy tube. Okay, so now this is an exchange between the airway and the voice. Patient loses voice a little bit, patient gains airway a little bit. Okay, and this is how a surgeon rationalizes that how much airway he has to create. Okay, because he will be giving away the voice in exchange for that. Right? Okay, now let's look in this operation. So this is one of the latest operations being done for bilateral recurrent laryngeal nerve palsy, and this is known as Kashima's operation. So this is done endoscopically, number one, and secondly, it is done with the help of a laser such as CO2 laser. So it's an endoscopic laser cordectomy. What is done in this? In this part of the vocal fold is cut. Okay, and when it is cut, what happens? It separates out and it creates a airway. Okay, and because of this airway, the patient is able to breathe. All right, again, it's a exchange between the airway and the voice. The more you cut, the more the voice will become bad, the more will be the airway. Okay, so you create only as much airway, the patient is comfortable, right? Let's look at this video. So it's a simple video of Kashima's operation, and you can see that one vocal fold, both the vocal folds are paralyzed, one of them is being cut. So we can see over here, this is being cut with the help of laser. Okay, so we keep on cutting with repeated carbon dioxide laser shots. Okay, and you can see as you cut, the vocal fold relaxes, it goes anteriorly, and you can see that there is a creation of airway. So we will cut it adequately so that an adequate airway is created, right? Okay, but we will not cut it excessively. If we cut it excessively, the airway will be much more, but the patient will have a very bad voice, right? So this is the Kashima's operation. Okay, the Kashima's operation, question asked in JIPMER 18 exam. Kashima's operation can be done for all of the following conditions except. Okay, so where all we can do the Kashima's operation? Number one, we can do in case of bilateral abductor palsy that we have just seen. Okay, other than that, where we can do it? In case of vocal fold dysplasia. So the vocal folds, they are not moving normally, there is a dysplasia, again we can do the Kashima's operation. Okay, what about CA larynx? Let's say there is a tumor over there that's causing the palsy, so we can cut the tumor, we can remove the tumor, we can also improve the vocal fold movement. Yes, sometimes in post radiotherapy cases of CA larynx. So CA larynx, there was a vocal fold palsy, you have done a radiotherapy, you have done CCRT. Okay, so we have done CCRT, concurrent chemoradiotherapy. Now the patient has improved. Okay, but there is a vocal fold palsy. Remember, in T3 stage, the vocal fold has undergone palsy. Okay, so you do a CCRT, patient improves. Now you want to improve the voice or you want to improve the airway. Okay, so what can you do? You can do the Kashima's operation. Nasopharyngeal carcinoma has nothing to do with Kashima's operation, so that obviously is your answer over here. It was a very pretty answer, okay, because this Kashima's operation deals with larynx, only one part, the nasopharynx is given, so it's a straightforward question. Answer is nasopharyngeal carcinoma. Okay, let's come over here to the bilateral superior laryngeal nerve palsy. Now sometimes, rarely, we can also have bilateral superior laryngeal nerve palsy. Now this is one of the most dangerous situations. Okay, why? You see, the superior laryngeal nerve, it supplies the external and internal. Now this internal laryngeal nerve is giving the supply to supraglottis, sensory supply to supraglottis, and is responsible for cough reflex. Okay, so let's say bilateral superior laryngeal nerve is gone, that means bilateral cough reflex is gone. And as I told you, the primary function of larynx is protection of airway. So if a foreign body goes inside your airway, you can barely survive for 4 to 5 minutes. Okay, you are more likely to die because of this obstruction, because of this aspiration. So this patient will land up in severe aspiration. Most of the times, you will find that this patient is already in the ICU. Why? Because the patient will be having so much aspiration that the patient may even aspirate his own saliva. You see, cannot even prevent the saliva entering into the airway. And with the saliva, the patient will have pneumonia, pneumonitis, aspiration pneumonitis. Okay, so the patient lung will be poor, patient will already be in the ICU, and patient may be on even ventilation because of the poor lung function. The pulmonary function will deteriorate very, very quickly. Okay, so now what can you do? Now there is a question asked over here. The question is about intractable aspiration? This question is sometimes asked in the exam. Intractable aspiration. What do you mean by intractable word? The intractable means that you have tried all the methods. Okay, you're still not able to treat a problem. So that's intractable. Okay, so intractable aspiration. Now, what can you do for intractable aspiration? What is the gold standard treatment? Okay, so before we come to intractable aspiration, gold standard treatment, let's first talk about severe aspiration. Now, patient is having severe aspiration. What all treatment modalities you can do? Number one, if patient comes to you with severe aspiration, the first thing that you can do is you can do a endotracheal intubation. Okay, and later on you can do a formal tracheostomy if you require it for a longer time. Okay, so usually the patients of aspiration, they require the securing of airway for a longer time, so you have to do tracheostomy straight away. Only in some acute cases of aspiration, you may go with endotracheal intubation, but in most cases, you have to do a tracheostomy to secure the airway. Remember, one of the indications of tracheostomy was to secure the airway, right? So you do a tracheostomy. So tracheostomy is one of the treatment modalities that can be used for aspiration. But what we do in tracheostomy, we make a hole in the trachea, we put a tracheostomy tube, you can inflate the bulb. So when you inflate the bulb, it will block the airway, okay? It will not allow any food particle to go into the lower airway. But around the bulb, some micro aspirations always take place. So tracheostomy is not a foolproof method. It's a temporary measure, right? It's a transient measure before you try for some other foolproof method. And it does not cause complete stoppage of aspiration. It decreases the aspiration, right? Okay, what other treatment modalities we do? Suppose there is an aspiration and aspiration is only for one side vagus palsy. So remember, for one side vagal palsy, unilateral vagus palsy, we did our thyroplasty type 1. This method not only improved the voice, it also stopped the aspiration. So this is done when there is unilateral vagus 10th nerve palsy. Okay, then we do thyroplasty type 1. But if there is a bilateral palsy, okay, there is a bilateral superior laryngeal nerve palsy, now there is no role of thyroplasty type 1. Especially in bilateral superior laryngeal nerve palsy, the recurrent is already functioning, the two vocal folds are meeting in the midline, so thyroplasty type 1 has no role over here. Okay, now somebody asks you gold standard treatment for intractable aspiration. So what does the patient wants? Patient wants complete stoppage of aspiration. So in this question, the examiner is asking you that gold standard means complete stoppage. Okay, you want to completely stop the aspiration in a patient in which you have tried all the methods and they have failed. Intractable aspiration. So what will you do? You separate the trachea from the food pathway, from the pharynx, from the esophagus. Okay, so you separate it. You separate the airway and the digestive pathway. That means you can do a tracheal separation and permanent tracheostome. Okay, you do a tracheal separation and permanent tracheostome. Now there will be separate airway and separate food pathway. Okay, let's look over here. What do I mean by this statement? So you see, this is the tracheostomy. What you do in tracheostomy? In tracheostomy, you make a hole in the trachea, you put a tube, you can inflate the bulb. So when you inflate the bulb, it will decrease the aspiration. Some can take place from the sides, some can take place when you change the tube, but it will decrease the aspiration. So that is a temporary or transient measure. Suppose patient has intractable aspiration, you want to completely stop the aspiration, what will you do? You will do a tracheal separation. So now you see over here, this trachea is separated, it is stitched to the neck and the patient breathes from here, right? The food pathway is separate. So you stitch the upper part of the trachea over here, so food pathway is separate now. Okay, now remember few things. This is a reversible procedure. Okay, it's a fairly reversible procedure. If the patient improves after some time, you can stitch back the trachea to the upper part. Number one. Number two, this procedure is a very short procedure. It can be done even in local anesthesia in the ICU. Right? This can be done in the ICU in the local anesthesia itself. You don't need general anesthesia for this small surgery. Right? Most of these patients are already having a bad chest, so obviously you cannot take them to OT4 and give general anesthesia. Okay, another possibility, instead of doing a tracheal separation, what we can do is we can do a total laryngectomy. Okay, so we can do a total laryngectomy and we can create a permanent tracheostome. So that means I am saying that instead of just cutting the trachea, you can remove this whole larynx. Right? And you can make a permanent tracheostome. But this procedure, it's a big procedure. It requires general anesthesia. You cannot do it as a small procedure. It will take few hours, 4 or 5 hours it will take. Okay, so this procedure is a big procedure. It requires general anesthesia. So in a patient with intractable aspiration, this is an impracticable solution. All right, so somebody asks you gold standard treatment for intractable aspiration. Gold standard means complete stoppage. Then you have to say tracheal separation and permanent tracheostome. Okay, right? Now so we have discussed the different types of focal fold palsy. We have also discussed the type 1 and type 2 thyroplasty. Let us discuss the remaining 2 types of thyroplasty. Okay, now before that, let's go to this question. A patient underwent lateral skull base surgery. Okay, so there's a lateral skull base surgery few months back and has presented with complaints of recurrent aspirations. So patient has recurrent aspirations. Right? There is no change in voice of patient. All right? There is no change in voice of patient. Which of the following nerve is most likely injured during surgery? Okay, we have 4 choices. Vagus, that is the 10th cranial nerve. We have the glossopharyngeal nerve. We have the superior laryngeal nerve and the recurrent laryngeal nerve. Okay, now what answer we can mark in this question? You see, if I say that there is a vagus palsy, let's say I assume there is a unilateral vagus palsy. So 2 things will happen in that. Which 2 things? Number 1, patient will have aspiration that we have just discussed. Patient will also have what we have discussed. Patient will also have, hoarseness. And this is not a transient hoarseness because the vocal fold will lie in cadaveric position. However, the question says there is no change in voice. Okay, now this, let's say there is a recurrent engine of palsy. Recurrent engine of palsy, patient only has transient hoarseness. Okay, but if there is a superior engine of palsy, you see, if there is a superior engine of palsy, patient will have number 1 aspiration. Okay, plus patient will have loss of pitch because of loss of the cricothyroid action. Okay, now let us say this is a unilateral palsy. Now you see, unilateral loss of pitch is not even noticed by the patient. So this thing patient will not complain. Patient will only come to you with complaint of aspiration. Okay, so patient has aspiration without any change in voice. So our answer has to be superior laryngeal nerve injury. Okay, so that is the answer to this question, right? Okay, so this question you have to analyze each and every choice. The glossopharyngeal nerve, of course, is not related to the voice. All right, so this nerve is not in the larynx. So this is how our answer is achieved. Okay, now let's come to the puberphonia. What do we mean by puberphonia? Puberphonia means female-like voice. Female-like voice. Puber means female, phonia means voice. So female-like voice in a male. Right? So patient has a female-like voice in a male. right? Now, usually at the time of puberty, what happens at the time of puberty? The anterior posterior diameter of the larynx increases in males. Okay, now because of this, the length is more and the tension also decreases in males. So in males, we have a low pitch voice, less tension, low pitch voice. Okay, females have a high pitch voice, right? Remember, females have a high pitch voice, more tension. So we know the females that take more tension, so females have high pitch voice, right? Males have low pitch voice. So suppose you are sitting in a library and you are studying. Now two boys, they're talking to each other, you may not be disturbed. But if two girls are talking to each other, you will be disturbed. Why? Because the pitch is high. Even when they speak normally, their pitch is high. So obviously, you are more distracted by the high pitch voice. Alright? So that's a natural phenomena. Now, puberphonia means a high pitch voice in a male patient. Okay? Now, what can you do for this patient? Suppose this patient comes to you. What can you do for this patient? Number one, you can check for puberphonia by a simple test that's known as Gutzman pressure test. Now what you do in this test, you take your thumb and you press on the thyroid cartilage. Okay, so when you press on the thyroid cartilage, the vocal folds, they are pressed anterior posteriorly, they go back, they relax and the pitch becomes a low pitch voice. So this high pitch voice converts into low pitch when you press on the thyroid cartilage. So that's known as Gutzman pressure test. It is done to confirm the puberphonia and whether we can improve this puberphonia or not. Okay, now how can you improve it? We can improve it surgically by doing a type 3 thyroplasty. Okay, so what is done in type 3 thyroplasty? You give two vertical incisions on the thyroid cartilage. So remember, the larynx, we have the hyoid bone, we have the thyroid membrane, you can see the thyroid cartilage, you can see the cricoid cartilage. Now what we do is, we give two vertical incisions on the thyroid cartilage and we take a part of this cartilage out, right? So you see, this incision is given and now this part, it goes inside and you can stitch it back like this. Right? So that's a type 3 thyroplasty. What happens? The anterior posterior diameter of the vocal folds, it decreases and the pitch therefore goes down. Okay? The vocal fold, they relax and the pitch goes down. This is your type 3 thyroplasty. It is done for puberphonia. Okay? Right? You can also call it as shortening thyroplasty or relaxation laryngoplasty. Okay? Now, type 4 thyroplasty is done in androphonia. So what do we mean by androphonia? Andro means male. Phonia means voice. So male-like voice in female. Okay, male-like voice. So what is a male-like voice? Low-pitch voice. So a low-pitch voice in a female, that's known as androphonia. So how do we treat androphonia? We treat it by doing a type 4 thyroplasty. So what you have to do now? You have to increase the tension in the vocal fold. Okay, so what we do now? We give an incision. As you can see over here, we give an incision in the thyroid cartilage and we put a block over here. So this block, when we put on both the sides, okay, so we will put this block on both the sides. So what will it do? It will increase the anterior posterior diameter of the thyroid cartilage and therefore these vocal folds, they are stretched. Okay, so once they are stretched, now the length increases, the tension increases, okay, and the voice becomes high pitch. So that is your type 4 thyroplasty, right? Okay, now another way of doing type 4 thyroplasty is you pass some sutures from the thyroid cartilage to cricoid cartilage, and when you tie these sutures, you pull the cricoid cartilage up. So we already know that when you pull the cricoid cartilage up, that part we have already studied in the muscles. So when you rotate the cricoid cartilage up, it will lead to the arytenoid going posteriorly and stretching of the vocal fold. That is how the cricothyroid causes tension. It increases the length of vocal fold. Okay, it increases the pitch of the voice. So the same thing you can do, you can just tie the thyroid cartilage to the cricoid cartilage and pull the cricoid cartilage up. So when you pull the cricoid cartilage up, that will automatically increase the length of vocal fold and can cause increase in pitch of voice. Okay, so you can treat entrophonia by type 4 thyroplasty. Okay, this is a lengthening or a tensioning thyroplasty because we are increasing the length, we are increasing the tension of the vocal folds, right?